I have some good news and bad news. It is not about kidney, for whoever is thinking there's too many kidney. It's not about infectious diseases, but it is about one of the loves of my life, which is the electron microscopy used for the practice of cytology. But in this case, it's not what I usually do. I'll show you tumors and how I make the diagnosis. This is something different. I am trying to advocate for the use of electron microscopy for different techniques that are not using it and maybe wasting the opportunity to make a diagnosis. I am Elba TURBAT HERRERA. I am a pathologist, better known in this group as the wife of Guillermo. But I have a life other than that, although it seems not to. I practice primarily cytology. I do surgical pathology. I do kidney research. I do GU. I do breast. I do many things. But I am primarily a cytopathologist. So I have been the director of pathology at the Mitchell Cancer Institute at the University of South Alabama. I have trained 29 fellows in cytology in different institutions, and here I am. So how can we maximize the power of cytology with the young? I've chosen this because there's new therapeutic methods that have emerged that utilize rapid methods of destruction or ablation of tumors, which in some cases are executed without a firm diagnosis. And that, I feel, oh, I can't see the thing here. It's so dark. Don't darken the room so much. I want to see this. Okay, I can see it now. So, but using cytology together with EM, you can maximize the diagnosis performed before ablation. I have been part of these pre-ablation diagnosis in the University of St. Louis University, but now there's a new technique that has emerged. It's called histotripsy, and it's a non-invasive, radiation-free cancer treatment that uses targeted ultrasound waves to create macro bubbles, pulverizing and liquefying most commonly liver tumors, but now it's being used for other things. This technique is now FDA approved, and it's mostly being used for liver, but now it's approved for pancreas and other organisms. What are the advantages of this technique? It's non-invasive. You don't need to have surgery. And what it does, it converts the tumor tissue into a cellular lysate that can then be reabsorbed by the immune system. So, the interesting thing is that during the cleanup process of the destroyed tissue, the immune system learns how to identify cancer cells as threats. And this can enable the body to continue fighting the initial tumor by taking it away from the destructed area. Well, what they did is they've done different studies, and I'm telling you this so you need to know that we need diagnosis before. So the immune system has been used to clear the process, and because when the outer walls of cells are destroyed, then the antigens are exposed. The immune system is exposed to the antigens. They come and target it and destroy and clean it away. Well, but the important thing, in some publications, they have said there has to be a biopsy-proven tumor, but in many cases, it is not. And they're not using it for small renal masses as well, and they said which before were being embolized to destroy these tumors. But now they're talking about using it for large masses. They're going to be using it for prostate. They're going to be using it for breast, but something has got to be done so there's a diagnosis before this. So minimally invasive procedures for tumoral ablation have been around. And in 2004, we were doing it with radiofrequency. Now there's been thermal ablation of tumors. It can be either hot or cold. You freeze it or you heat it. And you can use it for renal, liver, lung, bone, and even breast. Embolization has been used as well. The important is that we need to, prior to ablation, there needs to be a precise diagnosis. EM can help with this. Because in order for the tumor not only to be ablated, but in order to know if it recurs. What about if you think you had a biopsy, you think it's hepatocellular carcinoma, but the one you're destroying, you're not so sure. And what about if it recurs, if it metastasizes, or if you want to do research with it? What are you going to be studying if there's nothing there? So this is important. Evaluate the results and be able to what techniques to use. Well, the cytopathologist, I believe, should attend these procedures like I've always done. Now it's not happening. A lot of them, we have a resident here, president, they're not going. And if they're going, they're just saying, oh, yeah, there's tumor. That's not good enough. And for you to be able to say what it is, you have to obtain samples for electron microscopy while you do the cytology. So that's my banner is timing. But in order for cytology to be practiced in a definitive fashion, the diagnosis must be rapid, must be precise as possible. That's where EM comes in. So during this destruction of these tumors is a radiologic process. The pathologists now, they don't want to waste the time standing there like I did for hours and hours trying to collect my little bottles for EM, for molecular, for flow. But that needs to be reinstated, because if when they're doing the procedure, there's a cytopathologist attending the process, then you can obtain what you need to speciate this neoplasm. Now they're talking about not only liver, but pancreas. Pancreas is a very difficult diagnosis to make by cytology. But pathologists, I believe, must be sure that no tumors are ablated without an attempt to make the most precise diagnosis. And for this, we need to now, never more than ever, rapid, precise diagnoses are needed if we're going to be ablating these tumors and treat them without knowing for sure. But we all do immunohistochemistry. Immunohistochemistry, as I mentioned the other day when Eric was talking, it solves about 85% of everything, of all the neoplasms, but many times you just don't know what to do with it. Or the immunohistochemistry is marking something different. So you need to, for those that like EM, has rekindled our interest to look for a better way. So, in the case of, they say liver is what is being ablated the most. So I'm going to show you that not all liver tumors are created equal. You shouldn't say it's a liver tumor, it's a liver tumor. There's different tumors. Many of them can be metastatic. So you want to know, is it primary? Is it metastatic? If it's primary, is it a hepatocellular carcinoma or is it a cholangiocarcinoma? You can do all the immunos you want. But to be certain, you need to include electron microscopy. Metastatic carcinoma is more of a problem because it could be from any organ. So you need to work it up very well. So I'm going to give you an example of a diagnostic difficulty that I have encountered. And I'm not going to bore you with many cases. I'm going to show you what's interesting. This was a 68-year-old woman with a mass in the right lobe of the liver, suspicious for malignancy to the clinicians. An FNA was performed. When I looked at it, I was standing there, and I looked at it. I'm up there with my bottles and my cytotech. There were clear cell features, and it looked like an adenocarcinoma to me and to everybody else there. And this is how the cells looked. You can see that the cells have clear cell cytoplasm, and they're very cohesive. And adenocarcinoma seemed fine to me, although it's in the liver, but the liver, a lot of tumors go to the liver, so that doesn't mean anything. So our working diagnosis was probably metastatic, possibly an adenocarcinoma. So this is the cell block here on the left that I have labeled it, which when we have the cell block, we do the immunohistochemistry. It was positive for HER1. Okay, yeah, it may be hepatic, but I mean, it doesn't look like it. That's why we went to electron microscopy. So we went to electron microscopy, which had collected. And by the way, our hepatic expert hated electron microscopy. She didn't want me to do it because it often proved her wrong. So she didn't like it. But here it is. This is our tumor, and this is the bowel canaliculus that Eric was showing us. And if you could see at a higher power, it has this tight junction, but it had these lakes of mucin. This is a higher power of this, and here you have mucin and glycogen, and these little this little bowel canalicular with tight junctions. So clear cell hepatocellular carcinoma was our diagnosis, and that's what we called it. Without EM, the incorrect diagnosis of metastatic carcinoma would have been made. In addition, a number of additional tests the patient would have to be put through, and to be able to to find the primary neoplasm, which was actually a liver. So, since cytology material is limited usually, the most effective diagnoses are, we have to put everything together. It's not like you guys have all this tissue, we have few cells, we have to put together the clinical history, the immunohistochemistry, the molecular, the flow. Whatever needs to be done, needs to be done. But electron microscopy is usually a very important piece of the puzzle. Well, these are everyday diagnostic problems we solve by cytology and EM, and this is a myriad of things that I'm not going to put you through it because we're going to go straight to the renal masses. Why? Because they're ablating a lot of these as well. So we want to know what. So EM is important in differentiating from the most ordinary, the clear cell, or conventional, the renal cell carcinomas, which is the most common type, and other types. So I have a case here that I want to show you so you can see that the proximal nephron gives rise to the conventional clear cell and also the papillary carcinoma. CD10 is a good marker. And then for the distal nephron, we have another group of tumors that I'm going to show you one of them. Clear cell. Clear cell has a very diagnostic image by EM, and I've done it many times. It makes people angry because you're saying is this and that, and when you look the combination of glycogen and lipid, and you say in the right context, it's renal cell carcinoma, clear cell type, ordinary type. But there are diagnostic difficulties. In this case, a 30-year-old black male shows up in my service with a renal tumor and numerous lung nodules. Very young man, and for this kind of horrible tumor. And this is how it looked. It had these groups of very malignant looking cells with prominent nucleoli. They were grouped together in groups like adenocarcinoma. They were forming glandular spaces. It was necrotic, highly necrotic. And like I said, this was a renal mass. Well, this doesn't look like a clear cell, but we just took all the samples and see the cells are very high grade. You see this is a neutrophil. These cells are like, the nuclei like 30 microns. They're huge. So we did CD10. It's positive, but sometimes the immunohistochemistry does not work. It is CD10 positive, but we said we need to keep on doing and look for EM. Now, he had lung nodules, and in the same procedure, they sampled the lung. And the lung was performed at the same time. The cytologic features looked identical to the ones in the kidney. Very bizarre looking. And they had these balls of tumor all over his lung. This is now the cell block. And the cell is very tight, it's fibrotic, it's necrotic. So we know we have something unusual. So the EM had polarity and large lysosomes. Look at the large lysosomes. And we were still thinking maybe this is a bladder tumor. And so the tumor looked like a high-grade transitional cell at first from the renal pelvis, and it had monofilaments, large lysosomes, glandular differentiation. It was polarized and apparently tubular differentiation of some cells. So a diagnosis of a distal nephron tumor, probably collecting duct, was in our differential. So, what did I do? He jumped on me. Here you go. So here we have some more of the tumor, and the tumor has junctions, and is very polarized. It had, when I talk this, that's what happens. I shouldn't touch that other thing. Okay, you can see I wanted to show you the small macrovilli. It has short, stubby macrovilli that don't look like the proximal tubule, more like the distal tubule. So let's see what else is there. Well, in this case, from the distal nephron, and we were thinking down here from collecting duct maybe. The problem is that collecting duct carcinoma and medullary carcinoma have similar features many a time, and this is like just for you to peruse. This is a proximal tumor of the kidney, proximal tubule, and it has these long, gosh, I hate to touch that, the long microvilli. This is not our tumor. This is our tumor. Has very short and stubby macrovilli and some glandular differentiation, which you can see here. So it's glandular differentiation and some tumors are very bizarre, very big nuclei. So now we thought, okay, renal medullary and collecting duct carcinoma, they both arise from the distal nephron. and they show similar features, very high-grade cytology. Sometimes these show features of both collecting duct as well as distal tubule differentiation. So we know CD10 was positive, but we know there's infidelity of immunohistochemistry that should have been proximal tubule, but EM shows not. That is not. So now it has distal nephron differentiation and renal medulla carcinoma can be distinguished from collecting duct by some clinical features. In this case, renal medullary carcinoma has an association with sickle cell trait. Now, I didn't know if he had sickle cell trait or not. He was African American, but that doesn't mean he had sickle cell trait. So since the features of renal medullary and collecting are overlapping, so we have to go to the history, and sure enough, the patient had a sickle cell trait, and so the diagnosis was made as a primary renal metastatic to the lung medullary carcinoma. The patient went to MD Anderson for further treatment, and they concurred with our diagnosis. So EM saved the day, as always. Now, I loved it when David showed his lookalike picture. By the way, I need one of those, because I always talk about the lookalikes, because in cytology, people say there's features of different tumors, but there's a lot of lookalikes. There's things that look like others. Unless you do EM, immunohistochemistry, you can't tell them. So I need that picture. So it's very important to use immunohistochemistry because of the lookalikes. And EM. Let me see what time I've got. Okay. So if you have a lookalike, you have several options. You either make a non-specific diagnosis of malignant tumor cells seen, or you use ancillary techniques. Immunohistochemistry and EM will help you make a more specific diagnosis and shorten the differential, if nothing else. But with EM, you can actually establish the diagnosis. This thing is so dark. So the use of EM, especially ancillary techniques, but my preferred is EM because that's the most definitive, makes the cytologic diagnosis more definitive and unequivocal. I like to say the buck stops here. I like to make the diagnosis, not say atypical cells are seen. So it narrows the differential diagnosis, if nothing else, and is useful in also determining the site of origin. So my favorite ancillary techniques are immunohistochemistry and EM, although flow cytometry, molecular, I'll do whatever. So why is EM so great for cytology? Ultrastructural clues are a mere extension of the light microscopic clues if you know what you're doing, and that is why they call it truly the big eye. In addition, both cytology and EM deal with small samples. I don't have but a few cells, but if the cells have some characteristics, they are joined some point, and therefore I know I can tell what they are. So now more than ever, like I mentioned, we need more precise diagnosis, and that's where EM comes in. So is EM useful for the practice of cytology? There's a few criteria present. It is more reliable in immunohistochemistry because I'm looking at it. It's not some color contest. Using combination with immunohistochemistry, you can draw the strengths from one another. And what specimens are suitable for cytology? FNAs, rinses, fluids of all types. But if the cells are few and you find some very small features and you do EM, you can make a diagnosis. And as EM is reported in the same report many a time, instead of addendums that take 2 weeks, then people can use it more. So I am all for it. This is the resurgence of EM. So to me, cytology and EM, it is so powerful. It is the perfect match. It clarifies cytologic diagnosis by looking into the cells themselves. It's rapid if you have a microwave method, and it's less expensive than the huge batteries of immunohistochemistry. Now, the indication and advantages of EM for cytology, you probably know it better than me, but if the patient is inoperable, you can't go out do a biopsy. You have to do it with the cytology. The immunohistochemistry can be equivocal, and you have those lookalikes to deal with. So obtaining the sample is very important. You need to get a good sample, and what I had all kind of trouble doing EM for cytology for years until I realized instead of me putting the sample somewhere. I aspirate glutaraldehyde into the syringe, let it whirl there, take it and gently put it, and then the cells are perfect. If you do it that way, you don't have a problem. So you preserve the ultrastructural features. So in conclusion, EM is my technique of choice when a large battery of antibodies are necessary to solve a diagnostic problem, or if immunohistochemistry is inconclusive. And the technique of choice in many cases when a precise diagnosis is imperative, or patients need to be put in a protocol. So favoring a technique to the exclusion of others is what sometimes some pathologists commit that mistake and creates a disadvantage for us. But I want to recommend through this, most precise diagnoses are required before you ablate, because you want to be able to follow up the patients, do case studies, and in case of recurrence of metastasis, you would want to know what you're dealing with. Pathologists, we need to remember, the ones that are here are pathologists, we need to remember that we're still the guardians of the tissue. We need to protect it, we need to use it to the best advantage. Thank you.